So I'm not quite sure where she's got to, but for the sake of time, I think perhaps we just will start anyway. My name's Anthony Gordon. I'm Professor of Critical Care based at Imperial College, and I'm going to be talking about vasopressin to prevent renal dysfunction. And I was told when giving this session as a clinical challenge that actually we should ask questions of the audience. So a bit of interaction is the idea. So hopefully you have your apps ready, and I have some questions that I want to ask you. You'll hear how I use vasopressin, but I'm interested to see what the audience thinks about vasopressin and then review the evidence, and then we'll summarize it at the end. So my disclosures and acknowledgements are shown here, and particularly acknowledging my funder, the NIHR, also their standard disclaimer, the views expressed are my own. So I'm going to start with the first very simple question. Are you guys using vasopressin? And if you are, do you use it as your first-line therapy, second-line therapy, but early, second-line, but as late rescue therapy, or you never use it at all? And when I say never, I'm including, meaning you never use terlipressin or any of the analogues. I know vasopressin not available in every country. So if you go to the app, voting, we're in Glasgow, you should be able to see the question. And I messed it up myself. I can't vote now. Okay, last few seconds. So, majority of you using it as second-line therapy and late. The Surviving Sepsis campaign certainly suggests using it as second-line therapy. And I'm not so sure whether it's early or late, but we'll review that. Now, this is only for those of you who are obviously using it. Why do you use it? Is it to improve survival, reduce the risk of AKI, to treat it once it's established, reduce the risk of arrhythmias, or reduce catecholamine use? And again, vote now. You can vote for more than one this time. There's multiple choices, so you can select more than one. Okay. So it's mainly to reduce catecholamine use. So not so much for its own benefits, but maybe to reduce the harmful effect of other drugs. Okay. And improve survival, a larger number as well. Okay, we'll review the evidence for that. But if you're not using it, why aren't you using it? Is it because you think it doesn't improve survival? Because of digital ischemia risk you worry about? Mesenteric ischemia? All of the above? Or you think it's too expensive? I suppose we could also include it's not available. Again, you can vote for more than one. Okay, so mesenteric ischemia is the biggest concern that people have. Okay, so hopefully as I show you the evidence, maybe your views might change. I'm not going to ask you again at the end. I have a different question at the end, but it will be interesting. I'll point these the data out for these points that you mentioned as we go through. So just a little bit of reminder, physiology. Vasopressin, it's an endogenous hormone reduced from the posterior pituitary, a non-peptide. And in health, while we're all sitting here, it's involved in osmoregulation. It is antidiuretic hormone. And it works by binding to V2 receptors in the distal convoluted tubule, helping you to hang on to fluid. But in shock states, it changes, levels rise, and it becomes a very powerful vasoconstrictor. It binds to different vasopressin receptors, the V1 receptors on vascular smooth muscle. And it's this distribution of these V1 receptors, the heterogeneous nature of them, that is particularly interests people, and particularly around the topic of renal dysfunction, is there are more of these V1 receptors on the renal efferent than the afferent arterioles. And this is thought that, therefore, it may help maintain perfusion and flow to the glomerulus, so maintaining GFR. Whereas if you compare it to norepinephrine, which has equal number of adrenal receptors on efferent and afferent, it's thought that may reduce GFR. So it may have some benefits based on its physiology. What is the evidence for that in clinical practice? Well, this small study, sort of physiological study done in Canada, 24 patients, they randomized patients who were already on norepinephrine, so they had septic shock, and then they substituted a blinded infusion for just 4 hours of either norepinephrine or vasopressin. The nurses kept the blood pressure targets the same in both groups, so there was no difference in blood pressure. But when they substituted the norepinephrine for vasopressin, you can see here on the right that urine output went up in that 4-hour period. Looking at creatinine clearance over that time as well, even with the same blood pressure, just as 4 hours of infusion of vasopressin, creatinine clearance improved. So it seems to be having some role, physiological effects in the kidney. Another Canadian trial, similar-sized trial, 23 patients, where they randomized patients early within the first 12 hours of septic shock. In this trial, they were really trying to substitute vasopressin for norepinephrine, so actually going up to very high doses, up to 0.2 units per minute, which I think is actually a very high dose. But again, this was a physiology study, not looking at outcomes, and they measured multiple physiology outcomes. But interestingly, over the 48-hour period where they gave the vasopressin, you can see that there was a reduction in organ failure scores. The SOFA score was lower in the vasopressin-treated patients. When you break that down, which organ was improved? It was actually, again, the kidney we saw improving. This is creatinine clearance, comparing the vasopressin, the norepinephrine patients. And you can see that the vasopressin patients, again, over this now just 2-day infusion period, seem to have better renal function. So that's the physiology that would support that it may have a role in supporting the kidney. But what about patient-centered outcomes? Patients don't care too much about their creatinine clearance. Well, the first big trial looking at this, looking at patient-centered outcomes, this time 28-day mortality was its primary outcome, the VAS trial. Again, it was adult patients with established septic shock, where they added in a blinded infusion of either vasopressin or norepinephrine, vasopressin up to 0.03 units per minute. And you see that the dotted line is the 28-day mortality, the primary outcome. There was no difference in survival. Maybe a suggestion of some improved survival when you followed the patients up to 9 months. But overall, no difference in outcomes between these two groups. It was nearly 800 patients. Importantly, I think it established, though, that the use of vasopressin was relatively safe. This is the list of the serious adverse events. You see almost identical rates between the two groups, and no big differences in the individual categories of SAEs between the two groups. So it suggested at least we had some evidence now that it was probably safe to use in clinical practice. But what about its effect on the kidney? Well, we did a post hoc subgroup analysis to look at more detailed analysis. How did it affect renal outcomes? And we published this in Intensive Care Medicine nearly 9 years ago now, where we were looking at the effect on creatinine and so on in the groups. But we said, well, we obviously it's going to be different according to the degree of acute kidney injury when patients entered into the study. So we used the rifle criteria to categorize patients. And you can see particularly here in this risk group. So this is patients on the rifle criteria. The creatinine has risen 50% from the baseline. There was this improvement in creatinine over time. Here, the vasopressin-treated patients, you can see the creatinine comes down and stayed lower in those given vasopressin in that risk group. Perhaps a similar sort of signal seen in those without AKA at the time of entry into the study. Whereas if you compare that to the injury, or particularly the failure patients, where they've already got now established acute kidney injury, so the failure, the creatinine has risen threefold, you can see there's very little difference between the two groups. So suggesting maybe it was able to prevent the further deterioration of these patients before they developed renal failure. And that's when we looked at the risk patients in particular, you could see we almost halved the rate that they progressed to renal failure or loss with vasopressin. So this is patients halved the rate that they went on to receive renal replacement therapy. This sort of improvement in renal outcomes did lead to an increased survival benefit for the vasopressin-treated patients. So this is just taking that subgroup who were in the risk group at baseline. You can see the survival was improved in the vasopressin-treated group. But we must be cautious. This is a post hoc subgroup analysis. What about the subgroups that were a priori defined? Well, there was only one a priori subgroup analysis planned for the VAS trial, and that was around severity of shock at baseline. So how much norepinephrine were they on? And you see that it was this less severe shock who were on less than 15 mics per minute of norepinephrine at baseline, where there was a statistically significant difference in survival in favor of vasopressin, both at day 28 and at 90 days. Whereas if you compare it to the more severe shock patients, there was absolutely no difference. You can see the curves overlie each other. So this is interesting. A priori subgroup analysis. Of course, the hypothesis was the other way around. So this is interesting. We've got a planned subgroup analysis, but the complete opposite results. And as many of you said, it was these group of patients where you're using it in late, perhaps more like rescue therapy, where people are using it. We saw no difference, but it was these less severely ill patients where maybe there was some benefit. We explored it further. The reviewers for the paper said, well, can you explain it more? Well, we looked, are these patients earlier? Now, there was a 24-hour recruitment period for the VAS trial. Once you met the criteria, you had up to 24 hours to come into the trial. And we just simply split the groups into those who were recruited in the first 12 hours and those in the second 12 hours. And it's not significant, but the suggestion was if it was the patients who got enrolled in the trial early, given the vasopressin earlier, where maybe if there was any benefit, that was where it was seen. So how can we explain these subgroup results? Well, it could be chance. It was a planned subgroup analysis, but as we said, the hypothesis was the other way around. So if we're going to use this, we need another trial. But if we are designing a new trial, maybe we should think around reasons why it may have happened and design them into the trial. So is it the less severe shock patients, they needed the vasopressin earlier and we can prevent renal dysfunction? So we thought in a new trial we must give the vasopressin earlier. Another theory was, well, the more severe shock patients are sicker. Maybe they didn't benefit because we didn't give them enough vasopressin. Should we give them more? They got more severe shock. Maybe they need more of the vasopressin, so we'll go up to a higher dose. And so those were two of the key features in the VANISH trial that we ran in the UK a few years back now, and I presented actually the results for the first time in Berlin 4 years ago now. And in this trial, we used vasopressin, or included the patients into the trial early. Ideally, it's the very initial therapy, but that's quite tricky to do, involved in an RCT. So we said it had to be within the first 6 hours of the onset of septic shock. And they got randomized to a blinded infusion of vasopressin or norepinephrine. And we said, as I said, we would titrate it up, if needed, for the sicker patients, up to a higher dose, 0.06 units per minute. Now, this was a 400-patient trial. It was powered to look at renal failure-free days, or the number of days alive and free of renal dysfunction. And as you'll be aware, there was no difference at all in the primary outcome between the vasopressin and the norepinephrine-treated patients. However, obviously we were, as you saw, we were interested about its effect on the kidney. We had other important secondary outcomes pre-specified, including the use of renal replacement therapy. And here it was interesting. We saw a reduced rate of renal replacement therapy in the vasopressin-treated patients, 25% versus 35%, so nearly a 10% difference between the two groups. And of course, remember, this is a blinded infusion, so the physicians didn't know which drug they were given. Interestingly, once the patients had renal failure, the duration of the renal replacement therapy was almost the same in both groups. So again, suggesting it wasn't so much treating the patient's renal failure once it was established, but maybe preventing it getting worse. And then to show you this trial, this is not septic shock, but a very similar design to the VANISH trial. The VANX trial conducted in Brazil, but this time looking at patients with after cardiac surgery. So 300 patients, similar sort of size, again, going up to the higher doses of vasopressin versus norepinephrine. And this time, though, there was a composite endpoint. So it included mortality, but clearly mortality after cardiac surgery is always going to be low. So they had other post-op complications, including stroke, prolonged ventilation, deep sternal wound infections, needing to go back to the operating theatre, and acute renal failure were all listed. So a real mix of different endpoints. Well, they showed in this trial a clear difference between the groups in their primary outcome. You can see it here. 50% of the patients nearly versus 32%, so highly statistically significant difference. But this is a composite endpoint. What was driving that signal? Well, interestingly, again, when you look at it, it was the acute renal failure. You see a big difference here, an odds ratio of only 0.26. Confidence interval was well below 1. So it was, again, it was the effect on the kidney that was really driving the effect in this cardiac surgery patient. The other thing is, again, they saw that the drug was safe to use in this population. And when they looked at sort of safety events, you could see around arrhythmias, again, a big difference. Cardiac surgery patients obviously a much higher risk of arrhythmias, particularly AF. And you can see there was a big reduction in the vasopressin-treated patients. And I would say, obviously, the rate of AF is going to be more in cardiac surgery, but we see that in our sepsis patients. AF is always a risk. And so do we see similar effect in the sepsis population? Well, if we go back to the original VAS trial that I presented, when we looked at the hemodynamic effects, we did see effects on heart rate. This is looking at the effect of heart rate over time over the first 4 days between the two groups. And you can see that heart rate came down more quickly and stayed lower in the vasopressin-treated patients. When we looked according to those subgroups that we saw, the more and less severe shock patients, again, it was interesting. Remember, it was the less severe shock patients where we'd seen the potential mortality benefit. There was a much bigger drop in heart rate in the less severe shock patients treated with vasopressin compared to the more severe shock patients. So I think this is interesting. So although this talk is mainly about renal dysfunction, there are obviously other effects of these drugs. And is it, as we're realizing the benefit potentially of slowing the heart, people are even suggesting using beta blockers now to treat septic shock. Is this, again, some benefit may come from slowing the heart and potentially also reducing the risk of arrhythmias. And as you guys voted on, one of the reasons you use vasopressin is to reduce catecholamines. Is that its effect? Are we seeing this difference because, although we think of norepinephrine as an alpha agonist, we know it has some beta effects. And therefore, by reducing that, you reduce the tachycardias and arrhythmias? Or is it, in fact, some direct effect of the vasopressin, maybe via baroreceptors, leading to this reduction in heart rate? So those are the biggest trials that I wanted to present to you. And what we've done just recently, published a few months ago in Intensive Care Medicine, was an individual patient data meta-analysis. So taking the VANISH and the VAS trials, and at the time unpublished, the VANCS-2 trial, which is another Brazilian trial from the same authors, actually just come out in Critical Care Medicine. And we had access to their data and a small amount of data from Martin Dunz's group, who'd had some patients. And we had individual patient data, so we were able to look at subgroups. Overall, the top plot is showing 28-day mortality. You can see no sign of any effect on this survival difference between groups at 1 month. Serious adverse events, again, when looking at the total number, looks almost identical between the vasopressin-treated patients and the controls. Interestingly, in the bottom plot, you'll see the requirement for renal replacement therapy. And you can just see that there was a significant reduction, risk ratio of 0.86, confidence intervals just below 1, suggesting there's at least weak evidence that maybe it does reduce the requirements for renal replacement therapy. But with this extra data, we're able to look at the safety profile in more detail. And although the total number of events are the same in both groups, there are differences, and I think this is important to consider. When you look at rates of digital ischemia, they do seem to be higher in the vasopressin-treated patients. You can see the absolute risk difference here was significantly increased, 1.7 absolute risk increase with vasopressin. But equally, the rate of arrhythmias was lower, nearly 3% lower. Again, confidence intervals just below 0. So overall, they probably have the same level of safety, if you want to call it, but they have a different safety profile. And maybe this will help us decide which patients should or should not get vasopressin. And this meta-analysis is sort of consistent with another one that came out last year in JAMA, looking at all patients treated with both vasopressin and its analogues, and in any vasodilated state. And you can see here, again, their primary outcome we looked at was arrhythmias, atrial fibrillation, I should say. And again, you see a significant reduction with vasopressin-treated patients. And when looking at requirement for renal replacement therapy, the confidence intervals now cross 1, but again, that same signal coming through. And again, for the same, though, for safety, digital ischemia, again, there is this increased risk. As I said, with the IPDMA that we conducted, of course, we can look at subgroups. That's one of the advantages we can do. And so we're trying to find, is there a particular group of patients who may benefit most? And what we saw, the subgroups we looked at, was perhaps a signal here for looking at the degree of AKI at the time of enrollment into the trial. And there's a suggestion both when you look at 90-day mortality and the requirement for renal replacement therapy, that it's these patients without renal dysfunction or even just in the early stages that might get the benefit. Now, the interaction statistic for these subgroups is not significant, so we can't say they're behaving differently. But as a clinician, if I'm deciding which patients I want to think are more likely to benefit, it does seem that preventing the renal dysfunction may be the best way to get the benefit from the vasopressin. And I'll just finish with some sort of new evidence that's just coming out as we move to understanding that our patients we treat in critical care are heterogeneous syndromes. Can we actually identify subphenotypes who are more likely to respond differently to different treatments? And this group have defined different signatures for acute kidney injury. Now, they've taken variables that were measured, basically sort of inflammatory biomarkers and a few clinical characteristics, and doing this latent class analysis, which you may be familiar from Carolyn Calfee's work in ARDS, and they've got subphenotypes 1 and 2 of AKI. And they saw different effects on outcomes based on these subphenotypes. Subphenotype 1 looks slightly less severe group, and you can see here, particularly 28-day mortality is increased with SP2. So the second phenotype seems to be associated with the worst outcome, both in the discovery and the validation cohort. And this is using a parsimonious model where they use angiopoietin 2 and 1 and soluble TNFR1 receptor. So they can classify these patients. Well, this group then worked with the VAST investigators and looked at the effect in the original VAST trial. And they saw, again, these two subphenotypes. And what they saw here was if you were in this subphenotype 1, you had the better outcome when you were treated with vasopressin. If you were in the other phenotype, the more severe sort of AKI phenotype, there was absolutely no effect. Now, I think this is interesting work. It's new. Whether these phenotypes are just simply reflecting stages, illness severity, as I suggested earlier, patients with less severe renal dysfunction, I don't know. Or is it, in fact, two discrete subphenotypes? I think it's interesting work, and maybe we can identify the patients who are more likely to benefit from these different therapies taking this approach. And so it's that I want to finish with my last question. Oh, sorry, before I give you a question, I told you how I use vasopressin, sorry. So my personal choice, based on what I understand from the evidence, is that first-line vasopressin should probably be norepinephrine, and if all's going well, that's what I use. However, if that dose is escalating, I add in vasopressin. It is my second-line agent. And I think from what I've shown you the evidence, it makes sense to use it earlier rather than as a pure rescue therapy. I particularly use it if I'm concerned about renal dysfunction developing, and if there are problems of arrhythmias and tachycardias. Again, it seems sensible to use it in this group of patients, I think. But I do think a word of caution, particularly using higher doses and particularly high dose combination there. I think this is a risk of digital ischemia we do see. When we looked in the VANISH trial at the data, the patients who did have the digital ischemia were on both high doses of norepinephrine and high doses of vasopressin. So I think when you get up to these high doses, you do need to consider, can you bring them down? Maybe even accept lower blood pressure targets. And I know there's new trials, the 65 trial will publish later this year, and it'll be interesting to see if we can target lower blood pressures. So with that IPDMA came an editorial by the Australian and New Zealand investigators, and they said, okay, if this is what we know now, and what else do we need to know? And they suggested, if based on this data, if we were to do a new trial, they've suggested you would need 44,000 patients to detect a small difference in mortality. Even they admitted that was probably impossible to do, except if you embedded it within a registry. And so my final question for you is, if you were to see a new trial, what would you want done? Would you want one of these? They described it as a mega registry-based trial, a large trial based on mortality, a large but probably smaller based on renal outcomes, or would you prefer a subphenotype-enriched RCT looking at these more homogeneous groups, or you feel you don't need another trial, you have enough evidence already, or you just don't want another trial? They think there are more important questions. Okay. I'm glad you agree with me. This is the way I'm trying to take away, is this, you've gone for the enriched trial. I agree with you. I think we have to move to more of a precision medicine approach. Thank you very much.
I had a conflicting agenda, so sorry for that. Very sorry. So I think I just have to ask two questions in the audience, and then after the talk of Frederic Chambian, we will have more discussion. The first is, do you assume that vasopressin is equivalent to vasopressin? Thank you.
Do I think vasopressin is equivalent?
Yes.
It's very similar. I'm not sure it's equivalent. It has a different profile in how it binds to the V1, V2 receptors. It has a longer half-life. So I'm particularly concerned if you get the dose wrong and, when and you give too much. It's hard to undo it. So I don't use it for that reason. I know it's not available in every country, but I think using the shorter-acting drug, if you have the choice, makes more sense. So and there's more evidence for it. So I think vasopressin is a safer choice.
Yes, I agree. And there is a second question in the floor. What about combination therapy associating norepinephrine and vasopressin?
So I generally think that it's that combination that is better. So I start norepinephrine first, and then before it gets to too high a dose, I add it in. Simplistic view is when you go to high doses of drugs, you often get the side effect. If you can use lower doses of two drugs in combination, when we think we've got evidence that they're relatively safe, I think it's better to use a lower dose of two drugs than a high dose of one drug. So that's part of the reason.
Okay, thank you very much.